Welcome to the Pediatric Case Review channel. Today we'll explore Pediatric Inflammatory Multisystem Syndrome, also known as PMS or PMSDS. This lecture is designed for pediatric residents and fellows to understand the epidemiology, clinical presentation, diagnosis, and management of this important condition. Let's start with a case. You are seeing a 7-year-old boy with 5 days of fever, abdominal pain, and rash. His parents mentioned he had COVID-19 6 weeks ago. Which of the following best describes PMS? Is it a direct manifestation of acute SARS-CoV-2 infection? A post-infectious inflammatory syndrome occurring 2 to 6 weeks after COVID-19? A variant of typical Kawasaki disease unrelated to COVID-19? Or a condition only affecting children with pre-existing autoimmune disorders? The correct answer is B. PMS is a post-infectious inflammatory syndrome typically occurring 2 to 6 weeks after COVID-19 infection. The median age of affected children is 8 to 9 years, with a broader range than Kawasaki disease. There is a higher incidence in Black and Hispanic children, with an estimated occurrence of 1 in 3,000 to 4,000 SARS-CoV-2 infections in children. Understanding the underlying mechanisms of PMS is crucial. Which mechanism is believed to be the primary driver of inflammation in PMS? Is it direct viral invasion of tissues causing cellular damage, delayed hyperinflammatory response with cytokine dysregulation, autoantibody production against respiratory epithelium, or primary bacterial co-infection following COVID-19? The correct answer is B. PMS represents a delayed hyperinflammatory response with significant cytokine dysregulation. This post-infectious immune dysregulation features elevated inflammatory markers, including interleukin-6, tumor necrosis factor alpha, and interleukin-1 beta. PMS shares similarities with cytokine storm syndromes, with growing evidence of autoantibody formation and immune complex deposition contributing to the pathology. Let's discuss clinical presentation. A 10-year-old presents with persistent high fever for 4 days, extreme fatigue, and refusal to walk. Which feature of fever is most characteristic of PMS? Is it low-grade fever below 38 degrees Celsius lasting 1 to 2 days? High-grade fever above 38.5 degrees Celsius persisting for 3 or more days? Intermittent fever with complete resolution between spikes? Or fever only present during nighttime hours? The correct answer is B. High-grade fever above 38.5 degrees Celsius persisting for 3 or more days is the hallmark of PMS, present in over 90% of cases. This persistent fever is typically accompanied by extreme fatigue, malaise, and muscle pain. Headache and altered mental status may occur. Unlike typical viral illnesses, the fever in PIMS often persists despite antipyretic medications. Here's another case. An 8-year-old with 5 days of fever presents with severe abdominal pain, vomiting, and hypotension requiring fluid resuscitation. Which organ systems are most commonly affected in PMS? Is it respiratory and neurological systems, gastrointestinal and cardiovascular systems, renal and hepatic systems, or hematologic and endocrine systems? The correct answer is B. The gastrointestinal and cardiovascular systems are most commonly affected in PMS. Gastrointestinal symptoms occur in 80 to 100% of cases, including abdominal pain, vomiting, and diarrhea, sometimes mimicking acute abdomen or appendicitis. Cardiovascular involvement is equally common, with myocarditis, shock, and coronary artery abnormalities. Hypotension and tachycardia are frequently observed. Now let's discuss examination findings. A 6-year-old presents with fever, conjunctival injection, red cracked lips, and a polymorphous rash. Which mucocutaneous finding is not typically associated with PMS? Is it bilateral non-exudative conjunctivitis, polymorphic rash, strawberry tongue and red, cracked lips, or vesicular rash with clear fluid-filled lesions? The correct answer is D. Vesicular rash with clear fluid-filled lesions is not typically associated with PMS. Common mucocutaneous findings include bilateral conjunctival injection without exudate, polymorphic rash that may be maculopapular, erythroderma, or targetoid, and oral mucosal changes such as red or cracked lips and strawberry tongue. Vesicular lesions should prompt consideration of alternative diagnoses like varicella or herpes simplex virus infection. Let's continue with cardiovascular examination findings. A 9-year-old with fever and rash develops tachycardia, hypotension, and weak peripheral pulses. Which cardiovascular finding is most concerning for severe PMS? Is it sinus tachycardia alone, mild hypertension, hypotensive shock requiring vasopressor support, or functional heart murmur? The correct answer is C. Hypotensive shock requiring vasopressor support is most concerning for severe PMS. Cardiovascular collapse is a hallmark of severe disease, with 50 to 80% of children developing shock requiring intensive care. Myocarditis may present with gallop rhythm, decreased heart sounds, and signs of heart failure. These findings require immediate intervention and intensive care unit level management. Understanding the diagnostic criteria is essential. Which of the following is not part of the World Health Organization diagnostic criteria for PIMS? Is it age 0 to 19 years with fever for 3 or more days? Elevated markers of inflammation? Evidence of SARS-CoV-2 infection or exposure? Or white blood cell count greater than 15,000 per cubic millimeter as an absolute requirement? The correct answer is D. A white blood cell count greater than 15,000 per cubic millimeter is not an absolute requirement in the WHO criteria. The actual criteria include age 0 to 19 years with fever for 3 or more days, at least 2 features of multi-system involvement, elevated inflammatory markers, no other obvious microbial cause, and evidence of COVID-19 or likely contact. While leukocytosis may be present, it is not specifically required for diagnosis. Let's review laboratory investigations. A 7-year-old with suspected PIMS has blood work drawn. Which laboratory finding is least consistent with PIMS? Is it C-reactive protein above 100 milligrams per liter, an erythrocyte sedimentation rate above 40 millimeters per hour, lymphopenia and thrombocytopenia, elevated D-dimer and ferritin, or normal troponin and B-type natriuretic peptide levels? The correct answer is D. Normal troponin and B-type natriuretic peptide levels are least consistent with PIMS. Cardiac marker elevation is seen in 75 to 90% of PIMS cases, reflecting myocardial involvement. Other typical findings include markedly elevated inflammatory markers like C-reactive protein and erythrocyte sedimentation rate, cytopenia including lymphopenia and mild thrombocytopenia, and elevated D-dimer and fibrinogen. Hypoalbuminemia and elevated liver function tests are also common. Now for imaging studies. An 8-year-old with 4 days of fever, abdominal pain, and hypotension is being evaluated for PIMS. Which imaging finding would be most concerning in this patient? Is it mild splenomegaly on abdominal ultrasound, left ventricular ejection fraction of 35% on echocardiogram, reactive cervical lymphadenopathy on neck ultrasound, or mild bilateral pleural effusions on chest X-ray? The correct answer is B. A left ventricular ejection fraction of 35% on echocardiogram is most concerning, as it indicates significant myocardial dysfunction. Echocardiogram findings in PIMS commonly include decreased left ventricular function in 50 to 60% of cases, coronary artery dilation or aneurysms in 20 to 25%, and valvular regurgitation. Other imaging findings may include mesenteric adenitis, terminal ileitis, ascites, pleural effusions, and ground glass opacities. Let's consider differential diagnosis. A 5-year-old presents with 5 days of fever, rash, conjunctival injection, and cervical lymphadenopathy. Which condition is most difficult to distinguish from PIMS? Is it Kawasaki disease, acute appendicitis, meningococcemia, or juvenile idiopathic arthritis? The correct answer is A. Kawasaki disease is most difficult to distinguish from PIMS due to significant clinical overlap, including fever, rash, conjunctivitis, and mucosal changes. Key distinctions include that PIMS typically affects older children, features more gastrointestinal and cardiac involvement, and more prominent shock. Other important differential diagnoses include toxic shock syndrome, bacterial sepsis, acute viral infections like adenovirus or Epstein-Barr virus, and macrophage activation syndrome. Moving to management. A 10-year-old with confirmed PIMS has tachycardia and blood pressure at the 5th percentile for age. What is the most appropriate initial management step? Is it outpatient management with close follow-up, hospital admission for observation only, ICU admission for monitoring and possible intervention, or immediate administration of intravenous immunoglobulin without hospitalization? The correct answer is C. ICU admission for monitoring and possible intervention is appropriate for this patient showing signs of developing shock. All suspected PIMS cases require hospitalization, with intensive care needed for hemodynamic instability, myocardial dysfunction, or respiratory distress. Initial management includes cardiorespiratory monitoring, cautious fluid resuscitation if cardiac function is compromised, and early consultation with a multidisciplinary team including cardiology, infectious diseases, and rheumatology. Let's discuss immunomodulatory treatment. A 7-year-old with PIMS has persistent fever and worsening inflammation markers despite initial management. Which immunomodulatory therapy is considered first line for PIMS? Is it intravenous immunoglobulin, anakinra, an interleukin-1 receptor antagonist, infliximab, a tumor necrosis factor alpha inhibitor, or cyclosporin? The correct answer is A. Intravenous immunoglobulin at a dose of 2 grams per kilogram is considered first-line therapy for PMS. Corticosteroids are often used concurrently, typically intravenous methylprednisolone at 1 to 2 milligrams per kilogram per day, with higher doses sometimes needed for severe cases. For patients who don't respond to initial therapy, second-line agents include anakinra for interleukin-1 blockade, tocilizumab for interleukin-6 blockade, or infliximab for tumor necrosis factor alpha blockade. Addressing thrombotic risk is important in PMS. An 8-year-old with PMS has coronary artery Z-scores of positive 2.2 and elevated D-dimer levels. What is the most appropriate antithrombotic approach? Is it no antiplatelet or anticoagulation therapy? Low-dose aspirin at 3 to 5 milligrams per kilogram per day, therapeutic anticoagulation with enoxaparin, or dual antiplatelet therapy with aspirin and clopidogrel? The correct answer is B. Low-dose aspirin at 3 to 5 milligrams per kilogram per day is appropriate for this patient. This is recommended for all PMS patients until follow-up in 4 to 6 weeks, and should continue longer if coronary abnormalities persist. Therapeutic anticoagulation would be considered for patients with large coronary aneurysms with Z-scores greater than 10, documented thrombosis, severe ventricular dysfunction, or significantly elevated D-dimer levels. Let's discuss complications and outcomes. A 9-year-old treated for PIMS 6 weeks ago returns for follow-up. Which cardiac complication requires the most prolonged follow-up? Is it transient mild myocardial dysfunction that resolved before discharge, persistent coronary artery aneurysms, resolved pericardial effusion, or normalized cardiac enzymes after initially being elevated? The correct answer is B. Persistent coronary artery aneurysms require the most prolonged follow-up due to risk of thrombosis or stenosis. While short-term outcomes for PMS are generally favorable with mortality less than 2% and most cardiac dysfunction resolving within 1 to 4 weeks, long-term surveillance is crucial for patients with coronary abnormalities. Other areas needing follow-up include monitoring for arrhythmias and conduction abnormalities, ventricular function and remodeling, and neurodevelopmental outcomes. Let's practice case recognition. During a COVID-19 surge, you see multiple pediatric patients with fever. Which presentation should most strongly trigger consideration of PIMS? Is it a 2-year-old with 2 days of fever, rhinorrhea, and cough? A 10-year-old with 5 days of fever, abdominal pain, rash, and hypotension? A 7-year-old with 1 day of fever, sore throat, and exudative tonsillitis? Or a 14-year-old with fever, ear pain, and purulent ear drainage? The correct answer is B. A 10-year-old with 5 days of fever, abdominal pain, rash, and hypotension should immediately trigger consideration of PMS. Key features warranting evaluation include persistent fever for 3 or more days, typical age group of school-age children, multi-system involvement with gastrointestinal, mucocutaneous, and cardiovascular symptoms, evidence of shock, and often a history of recent COVID-19 infection or exposure. Early recognition is crucial for timely intervention. To conclude our discussion on pediatric inflammatory multisystem syndrome, remember that early recognition through persistent fever, multi-system involvement, and inflammatory markers is crucial. Initial management includes hospitalization, often in intensive care, with IVIG and corticosteroids as first-line therapy. While most patients recover fully, careful follow-up is essential, especially for those with cardiac involvement. Thank you for watching this pediatric case review presentation. Please follow our channel for more informative content, and if you have any questions, leave them in the comments section below.